Hello and welcome to the iMedX Best of Day series here at our annual hematology meeting in San Diego, California. My name is Dr. Joseph McHale. I'm a hematologist at Mayo Clinic in Arizona, and I have the privilege of having my friend and expert in CLL, chronic lymphocytic leukemia, with me here today, Dr. Neil Kay.
Hi, Joe.
Neil, it's great to have you here.
Thank you.
Neil is a professor of medicine at Mayo Clinic in Rochester and has been known for many years for his work in CLL. So, Neil, let's talk a little bit about CLL here at our annual meeting. I know that there have been some very highly touted, prominent abstracts. Why don't we let you choose the first one that you want to discuss?
Probably we should start with the update on the AbreuTanam initial trial of phase 1b/2, which was reported by Susan O'Brien. And essentially that was an update from the original New England Journal publication, where patients who were both treatment naive and relapse refractory were given AbreuTanam at 420 or double that dose and then followed for some time. So this is an important update. The initial report had shown very high response rates irrespective of prognostic factors, including patients being unmutated IGVH or having 17p. And also there was some issues about toxicity in the original report. So this update was in fact quite reassuring. The response rates continue to be quite high, really in the 90% level still. Still
included even in those high-risk patients?
Included, yes, thank you. So even in the 17p and the unmutated IGVH and 11q, there are still high overall response rates. What has changed a little bit that's important to comment on is that over time the CR rates appear to be increasing. So from the original report, the treatment naive now, I believe the CR rates are up around 29%. For the relapse refractory, perhaps 10%.
So there are some patients who are getting into a deeper response even later.
Exactly.
So roughly how quickly do most people tend to get their deepest response?
It's still tough for me to estimate that based on the data, but it looks like responding patients will need to be on for months, if not a year or two, before we might know their maximal response, and that is an important treatment issue. It will not be 1 or 2 months, but for most patients who can manage to deal with the drug and are getting a response, it's likely that they should be thinking about a year or two in order to see the maximal clinical response.
And let's talk a bit more about toxicity, because I think that's been one of the challenges, despite the convenience of being able to take a pill so they don't have to see us in clinic as much. Exactly. Did we learn anything more about the toxicity side of things, the GI effects or others in this update?
Yeah, and that's also an excellent point to focus on. The original toxicities were reported as low grade. They still are, if you will, mostly low grade. We're talking about 1 or 2 SAEs. But still, they are not trivial in that it can be arthralgias, it can be colitis, it can be diarrhea, rash. Of course, the issues about atrial fibrillation, persistent hemorrhage. Those profiles have not changed, but what is apparent is that over time they seem to be less. So they may be much more prevalent when patients are first put on the drug, but then seem to be getting to be at a lower level as patients stay on the drug.
Is there much difference in toxicity between the upfront patients and those with relapse refractory, or is it kind of disease naive, as it were, in terms of the course of the disease, that those same effects can happen in either a newly diagnosed or relapsed patients?
I think the data would suggest that if you're older and you have relapse refractory, you may have more side effects. Okay. Part of that might, of course, be the sort of baseline health profile that an individual has.
So bottom line then, for the treating clinicians listening today, for those that are treating their patients with AbreuTanam, not a major change, still very exciting results with a single oral agent, but that perhaps if they're anticipating or longing for a deeper response, need to be a little bit more patient in getting
Exactly.
it. Okay.
I would agree.
What other abstracts would you like to discuss today, Neil?
Well, as a follow-up to the update by Susan O'Brien on the original phase 1/2 trials, there was an update on the RESONATE-2 trial, which is basically a randomized placebo, chlorambucil versus AbreuTanam. And in that case, it was for upfront use, all comers, irregardless of prognostic status. And as you know, that was the trial that resulted in approval for upfront CLL, upfront AbreuTanam for all CLL. And that this update is also important in that, again, there seems to be a very nice response overall for all risk groups. But because of the more prolonged follow-up, now the progression-free survivorship, there is a number now for the 17P patients.
Because before we had it wasn't hadn't reached yet.
It was not reached. And the current update does suggest that for 17P and P53, there appears to be somewhat of a fall-off from all other patients. Still, the good news is that the progression-free is out to 2 or 3 years, and the overall responses are as they were originally reported in the phase 1-2 trials. Toxicity profiles appear to be very tolerable, again with a grade 1 and 2, and this is pretty convincing data that AbreuTanam in the right patient is reasonable therapy for upfront use, as well as, of course, for 17P.
That's reassuring too, because I know one of the issues that had always come up with this is what happens to those patients that relapse? Do they end up relapsing with a much more aggressive disease? Do we have any more insight into that yet, or is that obviously if this is a treatment that's working for so long, even in high-risk patients, we're still going to go ahead with it, but there was a concern at some point that maybe when patients do progress on AbreuTanam, is it limiting any other options later?
Yeah, that's still a bit of an unknown. There is more insight into the molecular biology of these relapses. And there was a very nice abstract presented by Jennifer White from Ohio State, where they've had a very large experience with AbreuTanam, both in treatment-naive and relapse-refractory. And what they're doing is they're doing deep sequencing, looking for mutations in the BCR pathway. And their original observation that was also published in the New England Journal a few years ago showed that the PLC gamma 2 and C481 serine site in the BTK protein in the BTK gene were the most common abnormalities. And what these do is they convert the B cell receptor into not into being a competitive inhibitor with AbreuTanam, which means that there's an off rate rather than non-competitive. And it appears that the BCR is non-active kinase in the face of these mutations. That unfortunately does predict for relapse, but what was very helpful for all of us to know was that because they did these deep sequencing in sequence over time for patients, what they showed us was that these mutations appear well before clinical relapse, in some cases months before.
So almost predictive of the relapse to happen.
Absolutely, absolutely.
Now is this, I assume, not quite ready for prime time yet?
As a CLIA-based test, for example,
correct.
I believe it's being done routinely at Ohio State, but and should be, in my opinion, it should be available, but is not routinely available.
So for our clinicians listening in, this might be something that in the near future they would have at their disposal to be able to see if someone is going the way of relapse before it's clinically evident.
Absolutely, and I would emphasize that that does need to occur for another reason, which is that we now know that for patients who come off of AbreuTanam, if they are progressing, or even for toxicities that are not tolerable, if we do not have a plan that's ready, there may be very explosive disease in that setting. Okay. So I think having those mutations available, that information available on those mutations in advance is likely going to be crucial for management of AbreuTanam exposed patients.
But bottom line now, from both of these studies, AbreuTanam is still highly effective in both the upfront and the relapse setting across risk groups with what we've come to appreciate as manageable but significant toxicity.
Yes.
So let's turn a little bit to the maintenance side of things. I know that was another topic of great discussion in the last few days. Let's talk a little bit about maintenance lenalidomide in particular. Can you tell us a bit more about that?
So this really builds on some observations, if I can be a little self-serving, that we had noted in a CIT, chemoimmunotherapy trial using penistatin, cyclophosphamide, and ofatumumab, where if you can add lenalidomide to patients after they have a response, patients can be converted to minimal residual disease negative status, and it appears that, at least early on, that might prolong PFS. In the M1 trial reported by the German Civil Study Group at this meeting, they did add lenalidomide or placebo to patients who had received chemoimmunotherapy. So they were randomized to placebo or lenalidomide. Very low dose, I should mention that's important. Very different than myeloma doses, like starting at 2.5 milligrams And I believe ramping
Because
up...
myeloma, we use like 10 times that amount,
do.
but I understand.
Well, we do not. Patients wouldn't like that. So the original dose, I believe, was 2.5 milligrams, and it ramps up to around 15 if they can tolerate it. And what's encouraging there is that it does look like PFS is significantly enhanced for the lenalidomide-exposed CLL patients. And because this was a large trial conducted by the German CLL Study Group, I think it has impact for our practice. Although it isn't so easy to get lenalidomide, it's still for CLL patients because of some toxicities that were reported several years ago. My strong biased guess is that it should be used in maintenance, but is not a common practice, not an accepted practice yet.
But maybe with some more confirmatory data, we might go that way. So again, if I'm a clinician listening in today, the maintenance lenalidomide story in CLL is reactivated again, and we think that this may be something of significance in the very near future.
Looks promising.
Okay.
Yes.
Other areas of CLL that we should chat about, Neil?
Well, not for prime time yet, but very exciting data is more on the clinical side. Again, and that includes the report on single-agent venetoclax, and then also on the combination of obinutuzumab, venetoclax, and AbreuTanam. And there were 2 abstracts reported, both from Ohio State, both by Jeff Jones. Single-agent venetoclax in relapse refractory, and also for relapse refractory in the triple combination. And if I could precede those data, it looks like it's safe to use in CLL with a ramped up dosing going from 50 to 400 milligrams. There is still a risk of tumor lysis, which is considerable. It's not inconsiderable, but it's interesting that these combinations are very effective. It looks like the response rates are quite high.
So even as a single agent in that context?
Even as a single agent. The combination is tantalizing because it would appear that because each one of those drugs has very significant and robust clinical activity, that if the holy grail is to get to a complete response with these signal inhibitors and to have MRD negative status, that may be the way to go.
And of course, each with a different mechanism of action enhances
Absolutely.
it. But for the venetoclax single agent, we think about that for a moment, because I know this has actually been a theme throughout the meeting, not just in CLL, but in other diseases, in multiple myeloma and other forms of lymphoma. We're really starting to see this agent, even as a single agent, being particularly active. So do you see a day where we might be using single agent venetoclax even in relapsed CLL?
Well, it's, of course, now it's approved, and one could use it in our own practice at Mayo Clinic. We're somewhat conservative about it because of the still considerable risk of tumor lysis syndrome. And for the relapse refractory patient, as we said before, if that's where we're using it, they're a little bit frailer, a little bit older, a little bit more beaten up. And so we are using it. We are beginning to use it. I think that the experience in the community setting will be perhaps slow because there is likely the possibility that many patients will have to be hospitalized and observed in order to gain more experience with the risk for TLS.
Because that's the question, is I know that when it was approved, it didn't sort of seem to get the immediate uptake that we might have expected with a novel. And I was wondering if these results might just further reassure or secure individuals. But I guess the tumor lysis question is still present.
One would think. Now, there is on that theme, there was a report at this meeting's ASH, again from the German CLL Study Group, where they, I think it's called the BIG trial, where they debulk with bendamustine. So they try to reduce the tumor bulk with bendamustine for a couple of cycles, and then they
introduce the venetoclax.
well, actually, wasn't venetoclax; it was AbreuTanam and obinutuzumab.
I see.
But that's the reason I'm bringing this up, is that if tumor lysis is a problem in the community setting or in academic settings, it may be that debulking is the way to go. Even in the Ohio State experience, their protocol for the triple drugs was obinutuzumab to debulk first,
I see.
and then going to the combination, to the doublet.
To the AbreuTanam and venetoclax together.
Yeah.
Okay.
It was kind of stepwise introduction, not all three at one time.
So I guess take-home message is obviously still very active agent on its own, these other two, of course, we've talked about both AbreuTanam and venetoclax, but indeed obinutuzumab, and still trying to find the ideal sequence and combination is yet to be determined, but obviously individualizing the decision to each patient. These are very active drugs.
Very.
Now, time's going quickly, of course, Neil. But if I could make you a profit for a moment or two, looking ahead to the future, what should CLL treaters be seeing down in the future for this disease?
That to me is a very crucial question. And one thing we do need to resurrect in a way, although I feel odd saying that, is chemoimmunotherapy. Chemoimmunotherapy still has a real place in the treatment of CLL patients, particularly for individuals who are young, who are not frail, who can withstand at least 3 cycles of chemoimmunotherapy, because the data, both from MD Anderson, as reported by Philip Thompson, also from the CLA trial, looks like those individuals who fit that criteria have what looks like a plateau out to 7, 10 or more years. So I still think that needs to be considered in the management of patients, and we should not be reflexly going to the new signal inhibitors for all patients. The other aspect that we need to keep an eye on is the immunotherapy. It looks like CAR-Ts, when they work, are very helpful and in terms of clinical response. And there was one abstract presented by David Maloney's group from the Hutchinson, where patients who had been exposed to AbreuTanam and relapsed were given CAR-T T-cell therapy, and that data looks amazing. Almost everybody got a complete response, and these were, again, pretty beaten up patients. So surely we're going to hear more about CAR T-cells and CLL.
So watching for a little bit of old and a little bit of new. Don't drop chemoimmunotherapy yet, but novel immunotherapy, CAR T-cell, which of course has been a theme right across the whole of the meeting in almost every area of malignant hematology to come. Well, Neil, thank you. This has been great, very helpful, very insightful. We appreciate your experience and your expertise in the area. And it's a pleasure always to have you.
Nice to be with you.
Thank you again for joining us for our IMEDX Best of Day series here in San Diego at our annual hematology meeting. We trust you found this helpful and relevant to you, and please be sure to join us for future publications and for future presentations. Thank you.